This portion of CardioSource video news coverage of AHA 2010 is brought to you by Novartis Pharmaceuticals Incorporated.
I'm Peter Block here in Chicago at the AHA annual meeting. One of the questions that's answered here at this meeting is whether or not ICD and CRT for heart failure patients is in fact a good thing, and it seems to be. With me is Dr. Tang from the University of British Columbia and Ottawa. Dr. Tang was the head of the RAFT study. So Dr. Tang, first off, tell me what the results of this study are.
The results of the study shows that resynchronization, when added to ICD and best medical therapy, reduce mortality and hospitalization for heart failure to a very significant degree.
So as I understand it, the reduction is about 7% overall. That's all-cause mortality. And tell me a little bit about the patient mix here.
Right. The patients are patients who have 80% of them are class 2 heart failure and 20% are class 3 heart failure. They all have low ejection fraction less than or equal to 30%. On the average, they were 22.6%. They all have wide QRS. Either they are conducted with a QRS that are greater than 120 milliseconds. In the study is averaging 158 milliseconds. Or that they have are paced with a QRS with pacing greater than 200 milliseconds. On the average, they are 210 milliseconds.
So they're actually pretty sick patients. You know, in MEDIT, patients had ejection fractions less than 30%, and I had sort of thought that this study might show benefit in patients somewhat less sick, but in fact their ejection fractions were low, weren't they?
On the average, the ejection fraction of this population as compared to MEDIT population was slightly sicker. We did not include class 1 patients as in MEDIT CRT did, and we do have 20% of our patients class 3. And also the ejection fraction is slightly lower by about 1 percentage point. In our population, 2/3 of them have ischemic etiology. I think in MEDIT CRT it was about 50-50.
Okay, so tell me a little bit also about your looking to the future. Do you think that these patients should be treated earlier? I mean, one of the burning questions obviously is if you have a wide QRS and your ejection fraction is 35%, should you have CRT? What do you think about that?
Oh, I think it's absolutely certain now with this data showing the mortality benefit and able to demonstrate that they are staying out of hospital for heart failure. I for sure think that these patients should be treated much earlier than we previously thought, and they should be all considered to have ICD as well as CRT.
Okay, so give me a take-home question here for everybody out there. What's the lesson from this trial?
The lesson for this trial is that we need to conduct a big study, and we need to conduct a study that is longer. And we are now demonstrating that I think without any questions that these patients benefit from CRT from a mortality point of view as well as reduction of hospitalization point of view.
So the combination of CRT and ICD seems to be the right thing for heart failure patients with low EFs.
Absolutely.
Thank you, Dr. Tang.
Thank you.
Special thanks to Novartis Pharmaceuticals Incorporated for supporting continuing coverage of CardioSource video news at AHA 2010.